like to express our appreciation to President Faust and to Harvard for their generosity to a project which touches many of our hearts. Virginia Hackney was my dear friend. Born with intellectual disabilities, her life was a journey of purity and splendor, laughter and love, community and purpose. For many of us who loved her, including her parents and sister who are with us today, losing her over 3 years ago to pancreatic cancer was a profound loss, but it was more. We also felt great inadequacy without knowledge or tools to help her understand all that was happening to her. What we realized is that the medical profession as a whole that lacks those skills and training and ideas that are not widely shared or simply don't yet exist to help intellectually disabled deal with their health, illness, and even end-of-life issues. Virginia was a spirited, active participant in life and never sat idly by on the sidelines. So in her tradition and her name today, we will begin a conversation. And we will hear from some of the top experts who have had the privilege to know and to work with the Virginias of the world. Now please welcome the new director of Harvard's Institute of Politics, Trey Grayson, who will launch our session.
Thanks, Caroline, for being such a fine fellow this semester. She's been one of our resident fellows at the IOP, and also for putting together this great conversation. So on behalf of Harvard Center for Public Leadership, as well as the Institute of Politics, I want to welcome everybody to today's discussion. It's a path-breaking discussion on healthcare and the intellectually disabled. Harvard's really proud to be able to provide a venue and support for such a vital public issue. We've got an extraordinary panel with us. They're going to share their insights and wealth of information about their years of service to this vulnerable population. We're very pleased to have Mr. Bob Johnson as our moderator this afternoon. He's going to introduce the panel. Now, Mr. Johnson's been with the Special Olympics, involved with the Special Olympics for over 22 years, and is the current president and CEO of the organization in Massachusetts. He's devoted over 41 years to serve and improve the lives of those with intellectual disabilities. Prior to joining Special Olympics, he dedicated 19 years to serving children and adults with special needs through various capacities in public education. He was a special education teacher for 6 years, a special education administrator for 9 years, and the Massachusetts Chief Compliance Officer for special education for 4 years. So after the panelists have each spoken, we'll open it up for question and answers. And we're always very informal here at Harvard, so by all means, there's some cake, as we call it in Kentucky out there. I think it's tiramisu or something fancy. Feel free to go get your dessert, get a refill and some drinks. The panelists will not be offended, and we're going to have a great afternoon. So, Mr. Johnson, thank you.
Thank you very much. Good afternoon. Some may logically be asking why the CEO of Special Olympics is moderating a health seminar. The reasons come back to one of our panelists here today, who I shall introduce in a moment. However, thanks to this individual, a man of great vision and determination, Special Olympics has become the world's foremost keeper of health-related data for people with intellectual and developmental disabilities in the world. As the world's largest amateur sports organization, serving 3.5 million people with intellectual disabilities in over 171 countries, Special Olympics has access and has used that access and the power of sports to bring about great social change both here and far away. After today, I hope you will think of Special Olympics as more than a sports program. I hope you'll think of us as a health organization and a human rights organization dedicated to providing both children and adults with IDD better access to quality health care so that they can ultimately live not just a longer life, but a healthier, happier, longer life through sports. Over the course of the past 15 years, Special Olympics has collected some very interesting data, and I want to share some of that with you today to kind of set the stage. Some of the things that we know about people with intellectual disabilities we can learn from Special Olympics athletes. We know that Special Olympics athletes, of Special Olympics athletes, 33% see poorly and need new or different glasses. 6% have serious untreated eye disease. They are 6 times more likely to fail a hearing test than the general population. 35% have obvious tooth decay in their molar teeth. 50% have obvious gum infections. 12% report being in pain. 15% require urgent care. 22% have bone loss. 65% are overweight or obese. 61% have foot problems or infections. They have a 40% greater risk of preventable secondary health conditions than do the general public. And they have 4 times more preventable mortality than the general population. But even with all of that, they receive only 2.7 medical visits compared to men of the general public who receive 3, women who receive 5, and children and elderly who receive 6. 30 to 40% see specialists, while 92% have medical needs requiring special care. An adult today in the United States with intellectual disabilities has a 1 in 50 chance of finding a properly trained physician willing to accept them into their practice. That, coupled with the life expectancy increase for people with intellectual disabilities that some say is as much as 26 years since the closing of the institutions back in the 70s. Their life expectancy is now estimated as high as 74. For people with Down syndrome, 57. This extended life expectancy brings with it a variety of unintended consequences, few of which have been dealt with in any systemic fashion. However, many are still seeing their pediatricians for things like cardiovascular disease, neurovascular disease, and testicular cancers. These facts are scandalous and contribute to the notion that people with intellectual disabilities continue to be the single most discriminated against segment of the population in the history of mankind, and that discrimination goes on today. I recently heard a quote by one of our panelists, as a matter of fact, who simply stated, "Pain does not discriminate. The solutions to it do." Today we have with us 4 individuals who have vast experience in this field, each of whom bring a unique perspective to the issue we face. The first is Lucy Durr Hackney. Lucy Durr Hackney began her public service career as a founder of the Pennsylvania Partnership for Children, an advocacy organization devoted to health care for children. In this capacity, she developed programs to provide early screening, immunizations, and family medical care to this vulnerable population. As a result of her work, Pennsylvania was the only state to inaugurate this benefit prior to the passage of the Child Health Insurance Program, CHIP. The Clinton administration modeled the CHIP statute on the Pennsylvania program. Mrs. Hackney actively served on the board of Children's Defense Fund in Washington, D.C. Her association with Marian Wright Edelman led her successful involvement with federal legislation affecting children. Currently, Mrs. Hackney serves on the board of the Martha's Vineyard, Massachusetts Community Services, where she has been instrumental in designing projects related to drug rehab, mental health services, Head Start expansion, and domestic violence. Her vision and work for children and their families has been recognized throughout the United States. Mrs. Hackney attended Radcliffe College and received a BA from Princeton and a law degree from Tulane University. She is the magnificent mother of Virginia Hackney. Next we have Dr. Stephen Gardner. Dr. Gardner is an internist at Massachusetts General Hospital and assistant professor of medicine at Harvard Medical School. He is the past medical director of Special Olympics and for 12 years has been a volunteer physician at the Martha's Vineyard Cerebral Palsy Camp, Camp Jabberwocky, the location and inspiration for many of his photographs. His photographs focus on the human spirit and specifically the resilience of people facing adversity and the compassion of those who care for them. It has been described by Dr. Carl Cooley of Dartmouth Medical School as a doctor, an artist who sees with his heart, and has been awarded the Harvard Medical School Humanism in Medicine Award in 2005. Third, we have Dr. Stephen Perlman, the gentleman I mentioned earlier. Dr. Proman is an associate clinical professor of pediatric dentistry at Boston University's Goldman School of Dental Medicine. He's devoted 30 years of his career, private practice, and teaching to the treatment of individuals with intellectual disabilities. He works with the Shriver family as they struggle to find adequate dental care for Rosemary Kennedy, sister to U.S. President John F. Kennedy, due to her intellectual disability. Dr. Proman's concerns about health disparities highlighted by Rosemary Kennedy prompted the research and studies that launched the Special Smiles program from his Lynn, Mass. Dentist office in 1993. The program later became the Healthy Athletes Program, part of the Special Olympics Global Initiative to provide better health care and better quality of life for Special Olympics athletes. The Healthy Athletes Initiative is dedicated to providing health services and education to Special Olympics athletes and changing the way health systems interact with people with intellectual disability. Through free health screenings, trainings for healthcare professionals, and evaluations of the health status, Healthy Athletes has become a powerful public health organization worldwide. And finally, Dr. Sheldon Hackney. Dr. Hackney is Professor Emeritus of U.S. History at the University of Pennsylvania. He specialized in the history of the American South since the Civil War. Out of his interest in American utopias and other social movements come an emphasis on the civil rights movement in particular, and the 1960s in general, which he frequently pursues in seminars. He is at work on a biography of C. Van Woodward, the noted historian of the American South. Among the articles and books on history that Professor Hackney has published, Populism to Progressivism in Alabama won the Albert J. Beveridge Award of the American Historic Association. Magnolias Without Moonlight is a collection of his historical essays. Professor Hackney is the former president of Tulane University, the University of Pennsylvania, and the former chairman of the National Endowment for the Humanities. He has written and spoken widely about higher education, national cultural policy, and the state of the humanities in American life. He is also the author of Following Virginia, the story of Virginia Hackney's inspirational story. Our plan now is to have brief presentations, 5 to 7 minutes by each of our panelists, and then to open the discussion up for questions and answers. And we'll begin with Dr. Lucy Hackney.
Lucy, can I start?
Sure.
This is the book that was just mentioned, and I think Lucy is going to read a segment from it. I'll start one copy going around this way. Just look at it to see what it is. It is a chronicle of Virginia's last year, basically.
Well, before I start talking about what I was going to read, I just want to say a little bit about not what I did in the past, but the fact that when Virginia was born, I had no idea she had disabilities, and I have to say, a really stupid doctor who I think didn't do very well. But she was amazing, and Dr. Spock was always wonderful because he kept saying, don't worry, don't worry. 18 months she'll be willing to finally get up and walk and all of that. And so I had the amazing experience of having Virginia as my child, having absolutely no idea that she had disabilities. So it was partly my ignorance of being very young. I got married right after I finished the last 2 years of Radcliffe, when Southern girls did that kind of thing. And as far as I was concerned, Virginia was just wonderful. And it wasn't until my sister, my older sister, who knows a lot more than I do about psychology and so on, and she took care of my Virginia briefly while Sheldon and I went off to New York City one time for a weekend. And she came back and she said, I think I have something wrong with Virginia. And I said, what is that? And she said, well, the way she uses her arm. And I said, what do you mean? And she said, when she picks up things, she goes like this. But for children, normal children, they pick up like this. And I was stunned. I said, well, that's really interesting. And it turned out, as I began to talk to doctors, that did have a range of disabilities. But it was wonderful for me to know that for 18 months, I just loved her so much, and I had no idea that there was any disability at all. So it's good to be an ignorant mother sometimes. Sheldon's going to talk a lot about her past, but one of the things that people don't think much about is what it's like to have a sister who has a disability. It is one of her siblings, and we have a friend here who has a child with disabilities that's known Virginia forever, and there are so many. And there is my daughter Lucy, Elizabeth, right there. That's right. She just came in. But there's so many people here that I just want to say are friends of ours who've known Virginia, and I guess about 50% of you have known Virginia over the years. But I wanted to really talk about Elizabeth, and when Virginia died, Elizabeth did the most amazing piece talking about what it was like to be the sister of a child with a sister with a disability. And if I cry, it's okay, because Elizabeth may cry as well, because we haven't. But here it is, Elizabeth was speaking at the church. Virginia was not a typical big sister. We did not share clothes. She did not teach me how to wear makeup or to do the latest dance craze. She did not give me advice on boys. On the other hand, she did introduce me to her favorite music. You know, the classics like David Cassidy, John Denver, and the songs from Grease and so forth. I loved it. Although she didn't teach me the typical big sister stuff, I did learn some very important lessons from her. Virginia always watched out for me. There is a family story from the time I came home from the hospital as a newborn. I was 3 weeks early and very small. Virginia was almost 6 years old then. My parents were entertaining guests when Virginia appeared in the room in her nightgown carrying me. She had managed to get me out of the crib and carry me into the dining room where my mother sat aghast, terrified that I would be dropped and hurt. My father managed to calmly procure me from Virginia's loving grasp without showing her any sign of the panic he felt. This was the beginning of the special relationship between Virginia and me. She was the big sister, and she meant to take care of me. There were times, however, that I felt the need to take care of her. From the very young age, I learned the importance of looking out for the little guy. Sometimes I was with Virginia when she was teased by naive bullies. I loved her, and I learned to stand up for her. My brother Fane had more than his share of playground brawls, protecting her at school. I learned while young that despite the sassy retort, sticks and stones may break my bones, but the world never hurt me. Words really can hurt. And besides learning that it is right to protect those who cannot necessarily protect themselves, I learned to be sensitive always to people's feelings. Although I never really knew how often my sister was taunted, I did learn recently that she did indeed have the ability to stick up for herself. The story goes, as told by Virginia, that she was taking a long time to pay for her bagel in one of her favorite breakfast haunts. The Bagel Authority, when a homeless man behind her had started mumbling about how long is it for you to get what you want, and called her some nasty names. This apparently was not the first time he had bothered her. Well, according to Virginia, she turned around and told him that she had a disability that made her a little slow, but what excuse did he have for being homeless? This is how she told the story anyway. I have to say it made me quite proud. Maybe all these years she could have stood up for herself. That might have saved Fame several black eyes. Virginia also taught me kindness. Besides the typical childhood roughhousing, noogies, dead legs, Indian burns, pinching, and finger pending, I can't recall a time in my life when we argued or said unkind things to each other. We weren't the kind of siblings to hurt each other's feelings because we knew about teasing firsthand, and she wasn't just nice to her brother and sister. Virginia always had been kind to everyone, young, old, white, black, physically challenged, mentally challenged. She loved everyone. She gave everyone an equal chance to her affection. And you can bet that if she does not like someone, there was a darn good reason. I've tried to be just as embracing of all kinds of people throughout my life. Virginia also taught me that it's far better to give than to receive. When she gave a present, she expected a hug, a kiss, and a thank you letter in the mail. Virginia loved giving presents. I'm sure that many of you have been recipients of her generosity. Last Christmas, when Virginia was under treatment for pancreatic cancer, we knew it would probably be her last Christmas. Maybe she knew it too, because she decided that instead of usual black dog merchandise that she habitually handed out as gifts, she would do something a bit more personal. She decided to knit scarves for people. On Christmas morning, she gave out the scarves, and it turned out she had inadvertently forgotten a couple of people in the family, and they jokingly gave her a hard time about it. She took this to heart. The next day, lo and behold, she showed up with 2 newly knitted scarves for the previously forgotten family members. One of them was barely long enough to wrap around the neck, and the other was long enough to wrap around probably 5 times. But she had done it, and in a very little time, too. These scarves had become reminders in my family of the generosity of Virginia. Patience, of course, was another virtue that I learned through living with Virginia. Sitting at the family dinner table was the occasion that put patience in the ultimate test. As you can imagine, dinner at the Hackney House when we were growing up was never really a child-friendly affair. My parents always had heated discussions about the latest political situation, and they talked about interesting books they'd read. There was hardly any gossip or news that a child might find interesting. Fane and I bore those dinners for years and years, and finally, at age 25, we were savvy enough to participate in dinner conversation. Virginia, however, was doomed to a lifetime of family dinners with long dinners, especially during holiday meals that went on even longer. Virginia took after her namesake, her grandmother Virginia Durr, as well as her mother in terms of social skills. I tried to learn from her. I've always been very shy, and Virginia has always pushed me to be more outgoing. As you can imagine, it was hard to blend into the background with Virginia at your side, introducing you to every passerby on Main Street. It wasn't always clear how she knew someone, but she seemed to know an awful lot of people. She not only knew a lot of people, she also knew the nicest ones. In the past 4 weeks, I have met some of the most amazing people I've ever met in my life. They are all friends and fans of Virginia. Fane and I always joked that she got all the social genes, and he and I were left with inability to recognize even our best friends in the grocery store. This past week, watching Virginia struggle against cancer, I've learned important lessons of courage and strength. She kept going about her daily schedule despite feeling tired and weak. The day before she died, she attempted lunch at Black Dog and later instructed us in how to fold the church programs for Sunday services. She was completely exhausted. No matter, at 5 o'clock in the middle of her short snooze, she opened one eye, glanced at her watch, and announced it's time to go to choir practice. But she was, I thought, I'm putting my foot down this time. No way she can have enough strength to go to the choir practice, but she was stubborn. She was now about to be told by her little sister what she could and could not do. Virginia was the best big sister God could have given me. She taught by example, and I tried to follow her lead. She taught me kindness, patience, acceptance, generosity, and she tried her best to teach me proper social skills. In her last days, she showed me her courage and strength. I am a better person for having known her, and I am the luckiest girl in the world to have her as my sister.
What a wonderful perspective. Isn't that just great? Dr. Gardner.
I feel like I'm a better person for knowing her, too. In fact, I know I am. And you didn't cry, so I won't cry. But I'm also the dad of a young man with a disability, so I have that perspective, too. And I'd probably start out by saying that almost everything valuable that I've learned in my life came from someone like Virginia or someone like my son, or the people who assist them. And to put that in sort of Shakespearean terms, you might say, the quality of mercy is twice blessed, and droppeth as the gentle rain from heaven on the place beneath, and is not strained and it blesses both the one who gives and the one who receives. And I've seen that over and over again at the Special Olympics. I've seen it over and over again at Camp Jabberwocky. And I've marveled at both the people with disabilities and the people caring for them, at the joy they find in that experience and what they exchange. If I may, I'll just follow up on Lucy's remark with one quick anecdote about Virginia and my son Graham. Virginia adored Graham and never failed to compliment him on how handsome he was. Each year she brought Graham a present, typically from the Black Dog, typically a trendy Black Dog t-shirt, and that happened without fail. Graham could count on receiving a colorful new shirt with the famous Labrador Retriever logo before leaving camp. When Virginia became ill, however, for the first time a camp session passed without Graham seeing Virginia. We were consumed by the frenetic pace of camp, as we usually are, and we didn't give it too much thought. Until a few weeks later, back at home, a package arrived from the vineyard, and there was a royal blue t-shirt from the Black Dog. We had heard by then about Virginia's cancer, and we reached her by phone at the condo where she still lived with fierce independence on Main Street in Vineyard Haven. Virginia, we're awfully sorry to hear about your diagnosis. How are you? Me? Don't worry, I'm doing fine. How did Graham like his t-shirt? I think a good society, the mark of a good society is its willingness to take all of us along on the ride. And I think we are a good society, and I think we are trying to do that. We need to get better at doing that. Let me just mention a couple of general problems that relate to this issue of intellectual disability and access to proper care. One of those issues is that it's hard to get primary care no matter who you are, whether you're able-bodied or otherwise. There's a shortage of primary care here and everywhere, and that's a complicated subject, probably a subject for another day. I'm lucky to be at Mass General, where I can proudly say that for the last 200 years the doors have been open to everyone, and no one gets turned away at the door. But that's not true everywhere. So access to care is a general problem, and access to care for people with disabilities is a subset of that, and a serious issue. I wonder what's going to happen to us if we continue to do better at helping people with cancer and disease. So if the Jimmy Fund is more and more successful, the Dana-Farber Cancer Institute and all the other places around the country and the world that are improving care for cancer, and we, at the same time, we help people with heart disease by controlling their cholesterol, diet, their diabetes, their blood pressure, their weight, and get them to quit smoking. What will we do if our life expectancy in America ends up being 90 or 95 or even 100 someday? We better be prepared to deal with people with cognitive impairment. And right now we're not prepared. And I don't pretend to know the answer to that, but I think a discussion like this begins to help us try to sort that out, at least to begin thinking about it. I was awfully lucky to know Virginia. All of us in medicine have patients where we feel at the end of the visit that they gave us more than we gave them. And Virginia was absolutely one of those people.
Thank you. Dr. Perlman?
Well, thank you for having me. And Caroline, I apologize to the group, but getting 7 minutes to talk about a lifetime of work and the most exciting things that I've ever done are happening now. And for the first time, I'm going to present a consensus statement that I and my colleagues have been working on. And I think I'm going to nail this whole thing about health care for people with intellectual disabilities, if I'm allowed to read it. But first of all, so health disparities, by definition, so I apologize for reading, but I got 7 minutes. Health, and I have adult ADD, and I gotta stay focused. Health disparities are differences in the incidence, prevalence, mortality, burden of diseases, and other adverse health conditions or outcomes that exist among specific population groups in the United States. For example, Hispanics are twice as likely to die from diabetes. Tuberculosis strikes Asian Americans at 16 times the rates of whites. Cancer kills 35% more African Americans than whites. If two patients have similar heart disease, a black patient is 1/3 less likely to undergo life-saving bypass surgery than a white patient. And among preschool children hospitalized for asthma, only 7% of black and 2% of Hispanic children, compared to 21% of white children, are prescribed routine medications to prevent future asthma-related hospitalizations. Among women with physical disabilities, more than 6 times are likely to experience depression, more than 5 times are more likely to have diabetes, are more than 5 times likely to have osteoporosis, are twice as likely to be obese, and nearly twice as much will suffer from hypertension. And now, for the first time ever, I would like to present a health disparities consensus statement that several years ago, the work that I was doing with Special Olympics I started to get calls from physicians all over the country and dentists that we needed an organization of specialists that really dealt with people with intellectual disabilities and a true organization of experts. And we've been working on a consensus on statement on health disparities for the past few months, and we have finally got it, and I'd like to just talk about it today. And I think I'm going to nail every point that needs to be addressed. I'm going to talk about 2 issues. What are the most important facts that we know about health disparities in people with intellectual and developmental disabilities, and the most important actions that can be now done to improve the situation. The most important facts we know about healthcare disparities in people with intellectual and developmental disabilities. People with neurodevelopmental intellectual disabilities are a unique and medically distinct population by virtue of genetic, biologic, developmental, and environmental factors that are the etiologic cause of their disability. Thanks in large part to decades of healthcare advocacy and specialization in the field of pediatrics, coupled with advances in medical care, people with intellectual disabilities are living longer with life expectancies in many cases that mirror those of the neurotypical population. People with intellectual disabilities consistently face challenges finding clinicians that are trained to treat them within a healthcare system that has no mandate nor model to treat them with the degree of excellence expected for all other conditions which impact health. The majority of physicians and dentists have limited knowledge regarding the health and psychosocial needs of this population, primarily due from a lack of exposure and training. Clinicians, as is true within society, often harbor limiting attitudes towards individuals with intellectual disabilities and contribute to the stigmatization and marginalization that often defines their healthcare experience. As a result, this population does not in general receive appropriate health promotion, preventive screenings, surveillance, or an approach to evaluation and management of health conditions consistent with that provided the neurotypical population. Patients with intellectual disabilities are rarely included in mainstream clinical trials and research efforts. Therefore, almost nothing is known regarding their suitability, response, or the clinical effectiveness of standard or emerging treatment protocols and guidelines. This severity hinders our ability to develop evidence-based or best practice approaches to care that increasingly defines the practice of medicine in the 21st century. Patients with intellectual disability are not adequately transitioned from pediatric to adult-focused care, nor based on the prematuring aging and medical conditions frequently associated with their disability to timely geriatric-focused care. The majority of newly graduated physicians, despite an interest in patients with intellectual disabilities, do not feel competent to treat this category of patients. Beyond this personal commitment, there are very few opportunities or incentives to receive pre- or postgraduate competency-based training. Despite decades of reports calling for changes in physician training and systems of care, and despite pockets of excellence across the country where quality care is a priority, there are no comprehensive national plan has been articulated or enacted to address these shortcomings. There is compelling evidence that people with intellectual disabilities are medically underserved. The United States Surgeon General reported on these health barriers and disparities, and yet, despite meeting the government's own definition of medically underserved population, HRSA does not recognize people with intellectual disabilities as qualifying for this designation. Minority patients with intellectual disabilities often experience ethnicity-related disparities in addition to those of their disability-specific condition. The lack of disability-related culturally competent care frequently compounds the challenges already faced by Hispanic and African American populations. Bob, do I have time for solutions?
Solutions?
I mean, for what are the most important things that could be done to improve the situation? Do I have
2 minutes, go for it.
people with intellectual disabilities should be formally recognized as constituting a medically underserved population by HRSA and other appropriate federal agencies, and receive the consideration, the benefits, the opportunities, and the assistance provided to this population with that designation. This designation, as well as the unmet healthcare needs of this population, should be acknowledged by established medical and dental organizations to address health disparities. Medical, dental, nursing, and allied health education curricula should include didactic and clinical opportunities for students to develop an understanding and appreciation of the unique qualities and rich opportunities possible for individuals with intellectual disability. These curricula should be designed to raise awareness, stimulate interest, and support developing not only clinical competence, but also skill in healthcare advocacy for patients, their families, and their caregivers. Healthcare providers should establish, formulate, recognize, disseminate, and adopt clinical guidelines, protocols, and best practices related to the health promotion, disease prevention, and specific treatment needs of patients with intellectual disabilities. In addition to intellectual disabilities specific core scientific and medical knowledge, education of healthcare professionals should include knowledge of the movement towards community-based living, education, employment, socialization, person-centered planning, self-determination, and quality health care that reflects the desired experience of this population. People with intellectual disabilities have both the right and natural inclination to live in typical settings in our community. Many need accommodation, supports, and resources to do so successfully. Physicians, dentists, and other healthcare providers, in their role as healthcare advocates, should strive with the same vigor and commitment as their vocational calling to facilitate and encourage this in a manner that fully honors the civil and human rights of individuals with intellectual disabilities, and above all else, commits to health parity and their highest quality of life as possible. The discipline of developmental medicine should be established with all the requisite components that define a specific and unique body of medical knowledge, expertise, and training. Specialists in this discipline would be trained to provide educational, research, and consultative roles while providing leadership in discipline and system of care delivery. These specialists would complement the role of the primary care medical home and support substantially subspecialty care physicians in their role of providing quality care to persons with intellectual disabilities in the same manner that they provide for their neurotypical patients. Compensation and reimbursement for healthcare professionals should be amended to reflect the additional training, time, special accommodations, and care coordination demands that are required to provide specialized care for this unique population. I apologize for reading and going so fast, but it was a lot of material, and I think a lot of people have been helping me, a lot of people have been working on this, and like I said, this is the first time that it's ever been presented in a public forum, but I think we nailed a lot of the points.
I think you sure did. I think it's a sad commentary on our society when our goal is to bring this population to the level of underserved.
I gotta tell you that I've been working on this medically underserved issue, trying to get it before Congress. The government has 4 guidelines to declare, right now it's done by race, ethnicity and zip code. And it's infant mortality, percentage of population over the age of 65, percentage of population in poverty, and number of primary care physicians per 1,000 people. That's the government's own formula for a medically underserved population. For the ID population, infant mortality rates are the highest in the nation. Only 10% of ID population lives beyond the age of 65, and 33% of this population live in poverty.
Startling statistics.
Yeah.
Thank you for that. Dr. Hackney.
I'm coming, actually, I thought that was fantastic. I'll come back to it in a minute and change what I was going to say, but let me say first how wonderful it is to see so many old friends here, and old friends of Virginia here in the room, especially, well, no, not especially, but including the president of Harvard. That's very nice, who knew Virginia also back in the past. And I must say that I'm really delighted to see these blue T-shirts. Not that your T-shirts are bad, but there was a solid phalanx of T-shirts. This is a new organization that is promoting the need for public attention to the question of autism in particular, but everything you said would also be appropriate for your goals. This event, indeed, may be one little instance that starts a national conversation about children and adults with disabilities of various kinds, and how the society has to pay closer attention to them and do something to allow them to live a more productive life. And those principles, this event, and your efforts, if it spreads, would be just fantastic. But that reminds me also of the fact that Virginia was born in 1958, in the middle of what I call the 1960s, the 60s, as it were. Now the 60s, to me, are a decade of 20 years, going from the Brown decision in 1954 to the resignation of Richard Nixon in 1974. That period was a time when it was maybe kicked off by the civil rights movement, promoting the rights of African Americans in particular, but other minority groups as well. But it begins with the civil rights movement as such, and then spreads. You will recall this is when the new phase, the modern phase of the women's rights movement gets kicked off in the early 60s. The lesbian gay movement gets kicked off in the late 1960s. And the student movement, or just the radical left movement in general for remaking society, gets kicked off too, as well as the anti-war movement in the 1960s. Now, one of the interesting things about these social movements that have a cause, such as the one that you're promoting, is that they begin frequently with a rather modest goal, and they attract people who come into the movement to accomplish that goal. Those people who come into the movement bring with them other goals, if you will, other values. So the movement not only is successful, but it begins to add elements to it, belief elements, values, if you will. It is also likely to be successful, and success makes the movement increase its goals to change society, and pretty soon you get a reaction from society against those increased goals, if you will, and that's what happened in the 1960s. And that reaction give you an example. The anti-war movement was extremely successful. The anti-war sentiment in the United States went up dramatically in 1967, 68, but also the anti-war sentiment went up at that time, which means the public came to not like the war, to think that it was a huge mistake, but they came to also criticize the anti-war movement. That's sort of typical of social movements in general. Virginia benefited from the fact that she was living at a time when public awareness of various conditions, including disabilities, eventually in the 1970s, that was increasing, and the general social values that support a society which supports people and provides opportunities for them to live as normal a life as possible, as independent a life as possible, was growing by leaps and bounds in that enhanced decade of the 1960s. We need another such period, which I think your consensus statement and goals enunciated very, very clearly. So maybe that's possible. For my wife and me, the experience with Virginia was dramatic and changed our lives in fundamental ways. We early came to the conclusion that our goal for her should be to try to see that she could lead as independent a life as possible. That was the goal, and that became her goal as well. It worked. She eventually, she exhausted the public education system in Princeton, New Jersey, where we were at the time, and had to go somewhere else. Lucy, my political wife, figured out how to get the state of Pennsylvania to pay some of the tuition for a boarding school for children with disabilities. So Virginia went to Elwyn Institute in the suburbs of Philadelphia, which was a great experience for her. Their emphasis was on making sure that she not only could read and write, which she could do at about a third grade level, but that she knew how to ride the bus, how to go to the bank, how to do all sorts of things in life that would allow her to live independently. And then when she came out of Elwyn, we were in New Orleans then, and she made the decision to go back to Princeton and live by herself, actually with a housemate, and she did. Now and we got involved also in establishing an organization in Princeton that would support children with disabilities. That worked.
She was a grown-up by then.
That's true. She was. She was. Pardon me, yes. That worked very well. She lived independently there. She held some jobs there. Then she eventually decided to move to Martha's Vineyard, which is where our summer home was and where she felt very much at home, and which is a community that is sensitive to people who have special needs. And she fit right in, and as you've heard in various people saying, she was an unusual person in that she was outgoing and friendly and got to know all sorts of people. The Vineyard worked for her, and because it was the sort of society that we need America to be, that is a society which cultivates and protects all of its members equally, and provides opportunities for them and can fix the problems that are there. That's what we need to be working toward. So the Martha's Vineyard experience for Virginia was very successful, and maybe we can do something to create a similar spirit of community throughout the country. Thank you.
Thank you.
Yeah. Can I just follow up on that comment?
Certainly.
So I watched, Virginia for a number of years down on the island of Martha's Vineyard, and it began to teach me that not only did Virginia benefit from being embraced by that community, but that community benefited from embracing Virginia.
Yeah.
And the whole place became better, more inclusive, more diverse, more fun, a stronger place, a more wonderful place. So it worked both ways. Absolutely.
Yeah. I agree.
As you can imagine, I have an opportunity in my line of work to interact with, obviously, many people with intellectual disabilities, but also with their families. And I have never heard a family member tell me anything other than that their child was a blessing. And that their child, they not only learned a great deal from their child, but their child has enhanced their lives in ways that a neurotypical child might never have done so. I think one of the things that we heard today is several perspectives from parents, from friends, from siblings, of people with intellectual disabilities, and what they all talked about is how much we learn from them and what a gift they are. We couple that with what we look at now as a rather dramatically extended life expectancy for people with intellectual disabilities. And we'd like to think that that too is a gift. But I think we selfishly define that as a gift for us, not for them. Some of them might tell you it's not a gift, it's an extended sentence. Because the life I have is not one that most people would want to continue any longer. The health disparities that Steve has mentioned and some of the statistics that I mentioned are difficult for us to perceive in our society today. One of the things that we've learned, I think, over all of us having 30 or 40 years of experience with this population is that change is not revolutionary, it's evolutionary. And that things are continuing to happen, and a great deal of wonderful work has been done over the course of the last 40 years, and probably more progress for this population has been made in the last 40 years than prior to that in the history of mankind. Our challenge is to keep it moving. When I present to my young staff and I look over at these young folks over here, and I say, don't sit on your laurels. Don't allow anybody to tell you that the work is done, because it isn't. Your obligation now is to bring about the same amount of change in half the time. And that's every generation's responsibility. Our athletes, people with intellectual disabilities, are counting on us. Many of them can't fight for themselves. They're counting on us. Unlike other discriminated against segments of our society, they don't have the power to rise up. We have to rise up for them. And your consensus statement, I think, is a great step forward. I hope it's embraced. And I hope that in our lifetime, my lifetime, not yours, my lifetime, I hope that we can raise them to the level of underserved so that they finally get service, because right now they are unserved, not underserved. Open it up for some questions, comments. Please feel free, just give me a high sign, yes.
First of all, good afternoon. My name is Courtney Thomas, and I'm a second-year Master in Public Policy student here. And as someone whose reason for coming to the Kennedy School was to make a difference in disability advocacy and policy, it's really a delight for me to be here today with y'all. And my question relates to gaining allies and support for the rights and needs of persons with disabilities. My older brother, Tinsley, is severely autistic and is nonverbal. And so for me, it's always been second nature that, of course, I care about the rights of persons with disabilities. Because of my parents' expectations that I would be his legal guardian, I've been a lifelong advocate for him. But I found that what's been surprising to me is that the rights of persons with disabilities is not something obvious to everyone. And so I would just like to know what have been your experiences of getting the rights of such a marginalized population, getting people who may have never thought about, what about persons with disabilities? How do you engage?
I wonder if I could begin on that one. I had the pleasure of speaking to about 1,200 high school students a month or so ago. And as I was walking up to the stage, I realized that I'm exactly 45 years older than the oldest person in the room. And I looked out at that crowd and I said, you know, unfortunately, it's my generation that's running things. And my generation grew up not having an opportunity to interact largely with people with intellectual disabilities, therefore not appreciating, not understanding, not respecting them. And as I sit across the table now from people that I'm seeking funds from to support our efforts, I hear their words, but I can see in their eyes they still don't care. The good news is my generation isn't going to be running things much longer. Yours is. And that's what's going to make the difference. Because you've grown up understanding, respecting, and interacting with people with intellectual disabilities, and you are willing to share your rights with them. And my generation was not.
Just a specific thing on autism. So at Mass General, the pediatricians take care of kids with autism, and then they turn a certain age, and there's a sort of a void out there. So a few months ago, the pediatricians came to us in adult medicine and said, could you do something about that? And so we took a baby step by agreeing, each one of us in primary care, to take one autistic young man or young woman into our practices, even though most of them were closed. Most primary care practices are closed these days. So that's a small step in one area of autism, where at least the kids coming up through pediatrics will be able to continue good medical care into adulthood through primary care. So if that is an example that we can apply to other disorders or conditions, then we'll be making some progress, hopefully.
Did you offer special training for these internists, for these primary care doctors?
No, I mean, not specifically, but I mean, since I've worked more with people with disabilities, I let people know that they were welcome to contact me if they needed some assistance. But most people are happy to do that. And in an academic setting like that, it's usually not hard to find assistance from somebody skilled in a particular area via email or paging or cell phones, whatever it might be.
Our research tells us that 93% of medical school deans will tell you that there is nothing in their curriculum to prepare them to treat people with intellectual disabilities. And 85% of graduating physicians have indicated a willingness and an interest in serving the population. You see the gap? Pretty clear.
Sir, I'm Jason Israel. I'm a second-year Master in Public Policy student. Thank you so much. And actually, just on that topic, I heard in Dr. Perlman's consensus statement, they discussed that the number of people that were graduating from medical schools, I don't remember the exact number, sir, but it was low, of people that have any preparation for serving this population. You used the word incentives, right, a word that we use often here in public policy. What are some of the public policy incentive gaps that we're seeing, and specific initiatives that we're writing policy papers every day about incentives, right? And to be able to make recommendations to senior officials. And I'm kind of looking at how would I create incentives to nudge some of the graduates of the medical schools into some of these programs?
Well, designating, for one thing, that's why we've been pushing so hard on this medically underserved population. For example, when you graduate any health profession school, you can get loan repayment by working in, everybody's got huge debts from finishing these programs. If you can work in a Native American reservation and get huge loan repayment, you can work in an African American or Hispanic health center and get loan repayment. But let's say you wanted to work in the field of special patient care in a developmental center or something to help. There's no loan they're not a designated medically underserved population, so there's no loan repayment. So that's a huge disincentive.
See the connection.
Second of all, research in the schools. They want to create, let's say, Harvard wants to start a program for developmental medicine. Well, if you want to study fetal alcohol syndrome in Native Americans or hypertension in African Americans, yes, they're medically underserved population, you can. You want to do anything in the field of people with intellectual disabilities or disabilities, they're not declared a medically underserved population. so there's no funding for any of these programs. You want to hire faculty. See, the two biggest problems that we've had in education, in professional schools, A, there's no faculty to train people, no trained faculty, and B, the schools don't make any money on this population because they're largely, like I said, 33% live in poverty. So they're working on a Medicaid system, and the Medicaid reimbursements are so pathetic in almost every state now. In Massachusetts, they're dropping adult care. We've always been one of the leaders in care, in dentistry. So no faculty available, no money for the schools to make, and the schools should actually be the safety net for the community, right? You know. So huge. We tried to push in the Council on Dental Accreditation. It had been inadvertently taken out. Schools had no responsibility in training anybody about healthcare for people with intellectual disabilities. We thought that this was an oversight because it had been in and not. So we petitioned the schools. We lost 30-0 to insert it in the curriculum. 30-0. We figured it was a mistake. Took it again to a vote. We got killed again. And only when we said we were going public did we get it passed. And only the most watered down version, that a graduate has to be competent in the diagnosis. No treatment involved, just in the diagnosis of a problem.
Just a quick follow-up on that. So just going back to primary care for a minute, we all know that we have these constricted periods of time in which to see patients, like 15-minute visits. And most of us in primary care, sort of cringe when we see a senior person in the lobby with a problem list of 15 serious issues. And we know that it takes them 14 minutes just to undress, leaving you 1 minute to address all those problems. So to take on somebody that you know will cost you more time, even though you may be well-intentioned and really want to do that, you have to somehow, we have to find some way of creating incentive for people to do that who are already maximally busy. And I don't honestly know the answer. I mean, we use this example of the autistic folks at Mass General, each person agreeing to take one person. That was a start. But that's just a start within a much bigger problem. Yeah.
Sir.
I'm Davis Weinstock. I was a friend of Virginia, sole distinction. It's a very cacophonous marketplace with a lot of competition for causes that need attention. I mean, my earliest memories of going to the movie as a 7-year-old or whatever, immediately with the end of, after World War II, was the lights went on and a little thing was passed around for the March of Dimes for infantile paralysis, and we had just come off of, I think somebody 4 times who suffered from that illness and had died 2 years before, was still missed, and attention was paid, and fewer organizations were fighting for the public dollar, and the eventual work by Dr. Salk and others that led to, in that case, prevention. Came an enormous amount of money translated into today's terms, and an awful lot of public sentiment and attention. In a political climate today that I work in politics, but I would welcome anyone else who could define the political climate today, because I couldn't. And with the 24/7 news cycle that's global, and with the competition for attention and dollars, have there been ideas? The statement's very helpful in consolidating, and statistics help working as a number of us do here with the Du Bois Institute. We see statistics that don't surprise us but shock us, and in a different area. Are there, to go to Congress and to get this designated, I understand the practical as an underserved aspect of medical attention. I understand the practicality of that, the incentivizing of doctors. As far as public awareness is concerned, autism was brought to the Children's Defense Fund, and you were serving with Bob, brought it there at that time, and Hillary Clinton was on that board with you at that time. I believe that not much happened. How do you galvanize public attention around the issue of cognitive impairment, around the problems and costs in medical service? Because without a wellspring of sentiment, particularly now with crazy people not only having been elected to office but being catered to, where I'm not sure anybody could really define by the political party with any commonality. I wonder how anybody has any thoughts of, because I don't, would welcome plans afoot to galvanize this on a broader basis.
This sounds like I don't mean to be that everything is getting better, but when I think about Virginia, this is 50 years ago, past 50 years ago. There was no education, no public education for kids with disabilities. The people who had enough money were immediately taken. Those children were taken off, never to often see their siblings. I mean, the Arthur Miller case is one that we all, probably many of us, have read. Here he was liberal in every way, working for good things. His own child was basically immediately taken off to a place for somebody to take care of him the rest of his life. That was, and Sheldon and I, when Virginia was getting ready to go get elementary school, the question was, where could we find some place for her to do something that would help? And I cannot tell you how many places we went supposed to find people that had lots of, people who had enough money to help to go to these places, and they would say, "Oh, darling, well, we will take her for the rest of your life, so you can be, she can be taken care of." And I said, "That is not what I want. Goodbye." I mean, it went over, and I must have done that. We must have done that 3 or 4 times with tears and Sheldon, but there has been a tremendous amount of change since those 50 years. It's that there's still so much more to happen. There's Virginia skating, and that was because of what you've been working for, and there she is, and she loved every minute of it, and it was huge for her. There's so many places that have things that have happened, and now we just need to do much more. But we can't be dismal. We've got to move on, because there's just a lot to do.
I think it largely does come back to the fact that for many years, people with intellectual disabilities were hidden away.
They were,
and
completely.
As a result, there was so little awareness of them, and today that's very different. I can tell you, I was telling Steve Perlman earlier, when I was in school, there were no people with intellectual disabilities in our school.
That's right.
When my kids went to school, they encountered them in middle school, junior high, high school. Yesterday, my 10-month-old grandson had a swimming lesson with a little girl with Down syndrome. It's working, it's happening, but we've got a long way to go. And we can't sit back, as I said earlier. I hate to point at you guys again, but you know, your level of awareness, your level of respect and understanding of people with intellectual disabilities, and your generation is going to make the next enormous change for this group, because of the fact that they haven't been given the way. Yes.
To just build on the galvanizing question, I'm Ellen Falls. I'm with the Institute of Politics Fellows Program with Caroline this semester, and so I look at things from a political viewpoint. Can you elaborate on, is there a specific piece of legislation in either the House or the Senate that people should get behind? What's the takeaway for all of us? Or what is the process with the AMA or something to move your consensus statement to a national resolution or something? What are sort of the big institutional things that could be happening, or what pressure could be put on the Obama administration to move the ball?
Yeah, I don't know. You know, it's interesting, this medically underserved push that we've been trying the last few years. We've met, I've had a one-on-one with the Secretary of Health, Education, and Welfare, and everybody says, yeah, I get it, we got to do it. And nobody does anything with it. And the interesting thing is that we're not asking for any, this is not an increase in budget. This is just taking whatever you're spending on medically underserved population and just splitting the pie differently. And I can't tell you, from early work with Connie Garner and Senator Kenny's office, and it's like, oh yeah, I get it, we're gonna do this, and every time we get somebody, we testified before the President's Committee on people within, you know, let me see, about 4 years ago, we were invited to talk to the President's Committee on people with intellectual disabilities about this issue. And the President's own, all the people on the President's Commission looked at each other and said, what are you talking about? How could they not be declared a medically underserved population? This is all we've been hearing about all the time. And they squashed it. Instead of, they voted at that session, they said it's going to be at the forefront of the report that goes to President Bush, and instead it was stuck at page like 68, where nobody paid any attention to it. And it was 1 year to submit it, he has 1 year to look at it, and then get back to you, and it's gone again. So, but even with the government's own form, I mean, what could be the issue? It's their formula, they created the standards. And now, from what I understand in the political, I mean, you guys have to help us. We're only a bunch of in the trenches, working healthcare providers that can't navigate through a system. You know, we can give you the documentation, we can give you the data. We've been collecting data. We have the world, Special Olympics has the world's best database. That's why all the governments want to work with us. We have 3.5 million athletes. You know, there's no more institutions. Everybody's living with their parents. Everybody's living in group homes. The governments have no way of knowing it's called secondary conditions. You know, we know how many people are born with Down syndrome or spina bifida, but we don't know how many people are born with autism. No government knows because they're diagnosed later. So we have the database of what are the secondary conditions that this population experiences. But it's an invisible population. 54 million Americans with disabilities, 7.5 million Americans with intellectual disabilities are invisible. Invisible. Every time I get something from the American Dental Association, it always focuses on African Americans, Hispanics, underprivileged. They're more worried about 12 Native Americans in some remote Alaskan village than they are about 7.5 million people with intellectual disabilities. It's been nothing but frustration.
It just seems to me that there really, in what you've said, there's not the mention of educating parents and family. Because without that education of what's possible for the families, you won't have such a strong movement. I mean, it seems to me, obviously Sheldon and Lucy educated themselves, but that is just so important.
I agree, empowering the parent is very important, but parents are so beaten down by the healthcare system, but so beaten down. I can't tell you the countless and countless patients that I've encountered throughout my career that know they're getting the worst medical care imaginable. I'll talk to somebody about a heart condition on an obese 40-year-old woman with Down syndrome, and I'll ask, is there a heart problem or not? And they'll say, well, the primary care physician, every time he tries to put a stethoscope on it, she pushes him away, and that's it. That's it. And I still get, when if I have to do patients in the hospital that I can't treat in the office, I always call the primary care physician to say, I'm going to do this case under general anesthesia. I can do anything that you want on this patient while they're under general anesthesia. And sometimes I'll get, well, they don't need anything. I have a 40-year-old woman. When was the last time she ever had a gynecological exam? Never. I can't do it. Don't you think I could do it for you while she's getting her teeth fixed? Don't you think it's important to do it? Well, I don't think she's sexually active. I don't know if it's necessary. What do you say? What do you say to somebody? And it's a woman physician that I'm talking to you. Would you go 20 years without a gynecological exam? Their parents are so beaten down that they accept any care, even though in their hearts they know it's wrong. Like Bob said, they're lucky to get somebody that's letting their daughter in their office. Sorry.
On the island of Martha's Vineyard, which is obviously by definition an insulated place, the level of awareness was very high across the board in that community, and hence acceptance and embracing of Virginia and the campers at Jabberwocky. So how would one translate that into a bigger place without borders where you don't run into them every day? I don't know. Any thoughts, Lucy?
Well, I think that the island is a very special place, and everybody knows everybody, so to speak. I mean, and people with disabilities, there are a lot of things that are working with people with disabilities on the island. I mean, that's something that people care about. It's not easy. I mean, it's not everything is wonderful, and the medical care. Obviously, Vineyard now is also connected with your.
You're talking about such a privileged population on the Vineyard.
Well,
it's not even a microscopic capture of what's going on in this country.
It's privileged
It's the poorest county.
It's a poorest county. Yes, it is privileged in the summer, in the sense, but it's the poorest county in Massachusetts.
I've never been.
Yeah. So, I mean, I think when I'm talking about the island across the way, not just the summer. The summer island, most of those people are not particularly interested. Some are, but it is an island, a year-round island where people do care about that. Yeah. I'm not saying it's perfect. It's not, but there is a real, and everybody knows and connects. It's part of what a community can be like. And that's one of the reasons that Virginia was able to live there. As Virginia would, my daughter would say, when they were living there, they were a little worried when Virginia said she was going to come and live in the Vineyard. And they thought, oh my God, we love her dearly, but how much responsibility are we going to have? Because we were still living in Philadelphia. Well, there was, Elizabeth, you can say there was just a lot of what was going on that she had that you didn't have to take care of her on a regular basis.
Dr. Hager?
I have another point to make, but we referred to that as the dignity of risk with Virginia.
And that is a very important one.
Very important. The point I wanted to make is that in the 1960s, this goes back to my social movement thing, in the 1960s, it was nonviolent direct action that put the civil rights movement and the anti-war movement in the national consciousness so that it couldn't be ignored. Now, I'm not arguing that nonviolent direct action would work in this case, but making the situation much more visible and making people with disabilities much more sympathetic in the public mind is essential, and we've got to figure out how to do that.
Right. Special Olympics has been probably the best
Special
example
Olympics
ever invented.
Yeah. But then you have to connect that public awareness of the folks in the Special Olympics, the public awareness of the connection of that to the problems that you're talking about.
Dr. Gardner, did you have something you wanted to add? We have time for one more question, and you're the lucky lady.
I'll try to be brief, although I see I have 3 minutes. I'm Lenny Wolf. I'm chair of the board of Camp Jabberwocky, Martha's Vineyard Cerebral Palsy Camp, and Virginia was a dear friend, and I'm forever indebted to her because she introduced my son, who was a counselor, to his bride, and they have been married for 2 years. Camp Jabberwocky, Steve alluded to it, is a wonderful example of community support. We could not exist without the support of Martha's Vineyard. Camp Jabberwocky is an 8-week overnight camp. It is run totally by volunteers. Dr. Steve, as he is known, volunteers his time. All of our medical people volunteer their time. And that is so inspiring to me. I don't have a home on Martha's Vineyard. I rent. To see these young people and older people volunteering their time to create experiences that are totally memorable. There's really not enough time for me to talk about what I really would like to say, but if you'd like to contact me, I'd be happy to share information. We do not, we have a wide variety of people with special needs, from cerebral palsy to Down syndrome to spina bifida, multiple disabilities, intellectual disabilities, physical disabilities. And we do not, even though we are a volunteer organization, it does cost us over $1,000 a week to run our 14-acre campus and provide a wonderful experience for campers. We do not deny admission for inability to pay. And in fact, we ask parents, if you cannot pay, if you can pay, we expect you to pay. If you cannot, just pay what you can. And families sometimes can afford $25 to $50 a week. But it is just a really inspiring place. We get donations from the community. We send out 2 appeal letters a year, and we have to raise through appeal, donations, foundations, tuition about $300,000, and we're in the black.
Good for you.
Anyway.
Well, I think that's a great way to wrap up. I think that since somebody here mentioned Special Olympics, I think it's programs like Camp Jabberwocky and Special Olympics that bring people to the center of the organization. We are a volunteer-intensive organization as well. We actually have 11,000 volunteers that work with us on an annual basis to serve our 12,000 athletes. But the volunteers serve both purposes, both the practical and the strategic. The practical aspect is we need them to get the work done. The most strategic part of it is it brings them to the center of the organization, gives them an opportunity to interact with people with intellectual disabilities, understand them for what they can do instead of what they can't do, and to appreciate them for the fact that they're more like us than unlike us. Many go home with an entirely different perception of people with intellectual disabilities, and if we've done that, and we've put a smile on an athlete's face, we've rung the bell. It's a great way to educate people, great way to give people an opportunity to become a little more enlightened about the population. Thank you all very, very much. It's 1:30 right on the dot. We appreciate everyone for being here. Thank you to the panelists.
I would like to express our appreciation to President Faust and to Harvard for their generosity to a project which touches many of our hearts. Virginia Hackney was my dear friend. Born with intellectual disabilities, her life was a journey of purity and splendor, laughter and love, community and purpose. For many of us who loved her, including her parents and sister who are with us today, losing her over 3 years ago to pancreatic cancer was a profound loss, but it was more. We also felt great inadequacy without knowledge or tools to help her understand all that was happening to her. What we realized is that the medical profession as a whole, that lacks those skills and training and ideas that are not widely shared or simply don't yet exist to help intellectually disabled deal with their health, illness, and even end-of-life issues. Virginia was a spirited, active participant in life and never sat idly by on the sidelines. So in her tradition and her name today, we will begin a conversation. And we will hear from some of the top experts who have had the privilege to know and to work with the Virginias of the world. Now,
Olympics athletes, 33% see poorly and need new or different glasses. 6% have serious untreated eye disease. They are 6 times more likely to fail a hearing test than the general population. 35% have obvious tooth decay in their molar teeth. 50% have obvious gum infections. 12% report being in pain. 15% require urgent care. 22% have bone loss. 65% are overweight or obese. 61% have foot problems or infections. They have a 40% greater risk of preventable secondary health conditions than do the general public. And they have 4 times more preventable mortality than the general population. But even with all of that, they receive only 2.7 medical visits compared to men of the general public who receive 3, women who receive 5, and children and elderly who receive 6. 30 to 40% see specialists, while 92% have medical needs requiring special care. An adult today in the United States with intellectual disabilities has a 1 in 50 chance of finding a properly trained physician willing to accept them into their practice. That, coupled with the life expectancy increase for people with intellectual disabilities that some say is as much as 26 years since the closing of the institutions back in the 70s. Their life expectancy is now estimated as high as...
Please welcome the new director of Harvard's Institute of Politics, Trey Grayson, who will launch our session.
Thanks, Caroline, for being such a fine fellow this semester. She's been one of our resident fellows at the IOP, and also for putting together this great conversation. So on behalf of Harvard Center for Public Leadership, as well as the Institute of Politics, I want to welcome everybody to today's discussion. It's a path-breaking discussion on healthcare and the intellectually disabled. Harvard's really proud to be able to provide a venue and support for such a vital public issue. We've got an extraordinary panel with us. They're going to share their insights and wealth of information about their years of service to this vulnerable population. We're very pleased to have Mr. Bob Johnson as our moderator this afternoon. He's going to introduce the panel. Now, Mr. Johnson's been with the Special Olympics, involved with the Special Olympics for over 22 years, and is the current president and CEO of the organization in Massachusetts. He's devoted over 41 years to serve and improve the lives of those with intellectual disabilities. Prior to joining Special Olympics, he dedicated 19 years to serving children and adults with special needs through various capacities in public education. He was a special education teacher for 6 years, a special education administrator for 9 years, and the Massachusetts Chief Compliance Officer for special education for 4 years. So after the panelists each spoke, and we'll open it up for question and answers. And we're always very informal here at Harvard, so by all means, there's some cake, as we call it in Kentucky out there. I think it's tiramisu.
74. For people with Down syndrome, 57. This extended life expectancy brings with it a variety of unintended consequences, few of which have been dealt with in any systemic fashion. However, many are still seeing their pediatricians for things like cardiovascular disease, neurovascular disease, and testicular cancers. These facts are scandalous and contribute to the notion that people with intellectual disabilities continue to be the single most discriminated against segment of the population in the history of mankind, and that discrimination goes on today. I recently heard a quote by one of our panelists, as a matter of fact, who simply stated, "Pain does not discriminate. The solutions to it do." Today we have with us 4 individuals who have vast experience in this field, each of whom bring a unique perspective to the issue we face. The first is Lucy Durr-Hackney. Lucy Durr-Hackney began her public service career as a founder of the Pennsylvania Partnership for Children, an advocacy organization devoted to health care for children. In this capacity, she developed programs to provide early screening, immunizations, and family medical care to this vulnerable population. As a result of her work, Pennsylvania was the only state to inaugurate this benefit prior to the passage of the Child Health Insurance Program, CHIP. The Clinton administration modeled the CHIP statute on the Pennsylvania program.
Feel free to go get your dessert, get a refill on some drinks. The panelists will not be offended, and we're going to have a great afternoon. So, Mr. Johnson, thank you.
Thank you very much. Good afternoon. Some may logically be asking why the CEO of Special Olympics is moderating a health seminar. The reasons come back to one of our panelists here today, who I shall introduce in a moment. However, thanks to this individual, a man of great vision and determination, Special Olympics has become the world's foremost keeper of health-related data for people with intellectual and developmental disabilities in the world. As the world's largest amateur sports organization, serving 3.5 million people with intellectual disabilities in over 171 countries, Special Olympics has access and has used that access and the power of sports to bring about great social change both here and far away. After today, I hope you will think of Special Olympics as more than a sports program. I hope you'll think of us as a health organization and a human rights organization dedicated to providing both children and adults with IDD better access to quality health care so that they can ultimately live not just a longer life, but a healthier, happier, longer life through sports. Over the course of the past 15 years, Special Olympics has collected some very interesting data, and I want to share some of that with you today to kind of set the stage. Some of the things that we know about people with intellectual disabilities we can learn from Special Olympics athletes. We know that Special Olympics athletes, of Special